what has been that your experience, especially dealing with cancer, with communities that are, their lifestyle is really a blend of culture, faith, and healthcare?
I think that's not unique to Africa, but what we do see certainly around many communities is the intersect. If we look at patients in sub-Saharan Africa, we see that many of the patients are diagnosed with advanced disease and frequently do not complete their care. And this, Vivian, tends to be an intersection of a number of factors. One of the factors is the fact that patients have to pay out of pocket in order for them to access care, frequently resulting in financial toxicity and catastrophic health expenditure. The second is the systems themselves sometimes are not responsive or reflective enough, where we know, for instance, that patients will see 4 to 6 healthcare providers before a definitive diagnosis of their cancer is made. But then sort of drilling down to the question you're asking about the social cultural barriers, again, these are very, I would say, depending on the community, can be very pervasive and actually determine what the outcomes are. And sometimes I say, telling a woman in sub-Saharan Africa that you have a breast cancer, for instance, is not just you have a breast cancer. It's you have a cancer. You could lose your, you could lose your livelihood because people sometimes get, discriminated on, discriminated because they have a cancer diagnosis. You could lose your family because sometimes you go home and you say, honey, I have a cancer, and you're told, honey, there's a door, don't let it hit you on the way out.
Yep.
I mean, there are many, partners who are supportive, and don't get me wrong, but it's still, pervasive enough to be a problem. And in our research, because as I said, my other hat is a cancer researcher, doing a deeper dive into the barriers behind this, we saw there's still a lot of stigma that exists around a cancer diagnosis. So, and sort of going in, I mean, of course, some of our pre-biases that we acknowledged as researchers was that perhaps this was something to do with the level of education. And so we did studies across East Africa where we looked at both high income and lower socioeconomic status, and our results were actually surprising because it didn't matter about the level of education or the socioeconomic status. The stigma actually sort of trumped everything else, and so patients, irrespective of their level of training, of their partners, or their socioeconomic, would still get thrown out of their homes and lose their sources of livelihood. And so that's one of the aspects of the social cultural barriers. Again, you've touched again on the use of alternative therapies and faith. As I said, that's not unique necessarily to sub-Saharan Africa, and we see different variations of that across different continents, but it's also enough of a hindrance to accessing care. One of the other things we always sort of discuss as clinicians is that sometimes when you have and patients come to see us on a routine basis and say, when you have a cancer diagnosis, at least in Africa, everybody becomes an expert, right? So patients will come in and tell me, Vivian, so what do I eat? I've been told don't take sugar, don't take proteins, don't take carbohydrates, don't take, you can only take vegetables, or you can't even take plain water, it needs to be alkalinized. So there's lots of things on social media and lots of things out there. And so it's really about how do you provide a platform that's providing safe, timely information and important information that really helps to, I would say, tackle some of these barriers. And then one of the critical things that's close to my heart is really around collectivism. And I would say in Africa, as I think I mentioned earlier, our strength is our community. But sometimes that's a double-edged sword, because what happens is, Vivian, you find that sometimes the patient loses agency. We've talked about, of course, Ubuntu and really having that community spirit. But then when the patient loses their own voice in that, it starts to become a problem. I'll give you an example as a breast surgeon. I frequently have patients who come in with early disease, and they sometimes, if it's a single isolated site, we have the option of either doing a breast conservation, meaning we remove just the lump, or we can do a mastectomy. And you sort of give both options to the patient and ask them to go home and think about them and come back. And then sometimes you'll come back with an entire clan, and there's the clan elder, and is like, we have decided, and we're like, who's we? Who's we?
Oh my goodness,
Who's
that is so
we?
true. Yeah, yeah,
Right?
yeah, yeah, yeah.
And you're like,
So sad and true.
and so it's like, we have decided she will have a mastectomy. And you're saying, but what does the patient want? And the patient's like, well, I would really like to keep my breast. But you see that this is the crux, Vivian. Unless we empower our patients, because she wants to keep her breast, but she's saying at the end of the day, they're the ones who are paying for it. So they're the decision makers. So how do we empower our patients, male or female, to have agency? And that can only come through health financing. We've really talked about thinking about structures around universal health coverage, access to care. We do need to think creatively, because some of our countries do have a national hospital insurance fund, but I mean, it's not infinite. Yeah. We do need to think about what are the creative ways of financing that we can start to build that would actually ensure that our patients are able to continue or at least complete their treatment journeys. So those are some of the issues that I think, well, I shouldn't say issues, some of the opportunities we have to intervene and make a difference.